The Department of Public Health and Human Services is pleased to bring you Aging Horizons. Medicare, Medicaid, Social Security, fraud, legal issues, veterans benefits, and caregiving. Aging Horizons is a program dedicated to inform and prepare Montanans on these timely issues, making a difference to you and your loved ones. Here now is today's program host.
Welcome to Aging Horizons. On today's show, we'll be talking about suicide prevention in Montana. We'll be talking about how we stand nationally in suicides. We'll be talking with the Montana Suicide Prevention Coordinator. We'll be talking about the scope of suicide here and how you as an individual can help intervene, or if you need resources, what resources are out there to assist you. So stay tuned.
I think the most pleasant surprise when we turned 65 and signed up for Medicare Part B was finding out about our Welcome to Medicare preventive visit.
It was free, and it gave us the opportunity to visit with our doctors and establish a plan for our health going forward.
They reviewed our medical history, measured our height, weight, blood pressure, and counseled us on other risk factors.
To learn more about Medicare's free or low-cost preventive and wellness benefits, call your local SHIP counselor at 800-551-3191. I mentioned it's free, right?
Twice.
This is Bill. He just received his new Medicare card and is following some simple rules to protect himself from fraud. He knows to never give out his Medicare, Social Security, or bank number over the phone. And this is Nancy. She knows that to detect any problems, she always reads her Medicare Summary Notice or Medicare Advantage EOB to make sure the billing is correct. Both Bill and Nancy know that anything suspicious can be reported to Montana SMP at 1-800-551-3191.
Receiving help for Ella has been life-changing, and the best word for it is relief. I was the therapist, I was the aide, and I couldn't be the mom because emotionally you're just to your wits' end. You're trying to survive.
I provide care for the Harrises, specifically their daughter Ella. Respite care is extremely challenging, but the rewards that you receive from it are 100 times more than working with a child that doesn't have special needs. Once they get something, it's everything. It's a you celebrate. You don't just enjoy those moments. You celebrate every moment that you get, that you guided them to that next step.
Respite. It's okay to need it. It's okay to want it. Will you provide it? Call 800-224-6034 or visit respite.mt.gov.
It went from survival to enjoying life and being able to be a mom again.
Brought to you by the Montana Broadcasters and this station.
Welcome to Aging Horizons, brought to you by the Department of Public Health and Human Services Senior and Long-Term Care Division. I'm your host, Brian Lamore. I mentioned earlier, today's show we'll be talking about suicide prevention in Montana. We are usually in the top 5 in the nation for suicides, and we're working really hard to address that, to bring that number down, way down. And we want you to know that, how can you recognize maybe signs of people that are considering it, how you can intervene, and if you're the one might be considering that, what resources that are available to you, because suicide's usually not the answer. Joining us now is Carl Roston. You're the Suicide Prevention Coordinator for the Department of Public Health and Human Services. Welcome back to the show.
Thank you, Brian. Nice to be here.
Well, we've been talking a lot of different times together here on the show, and Montana's way too high in the area of suicide. What are the statistics on that, and why is Montana so high?
Well, we've been in the top 5 for the last 40 years. As a matter of fact, if you go back to 1918 when the Office of Vital Statistics was created, Montana's been a top-tier state for suicide for more than 100 years. Oh. Our rate is almost double the national rate. But it's not just Montana, it's our region. If you take a look at the top 10 states, 8 of the top 10 are Rocky Mountain region states. So it's definitely a Rocky Mountain region area issue.
Yeah. So what makes it an issue? I mean, is it our lifestyle? Is it isolation?
A little bit of everything.
The
thing we know about suicide is that it's a multi-factor issue. Mm-hmm. And in the Rocky Mountain region, we really have a perfect storm as far as all these things happening at the same time. We have issues like our geography. We're a northern state, which means we get less sunshine, which means we have less vitamin D. Vitamin D deficiencies are correlated with an increased risk for depression. Oh. We have some of the highest risk groups for suicide. We have a lot of them in Montana. We have a large population of veterans. We have a large population of American Indians and middle-aged white men. Very high. Issues around alcohol use. Montana is routinely in the top 5 for alcohol consumption, alcohol-related death, DUIs. Well, about almost 40% of the suicides in Montana, there's alcohol in the system at the time of their death, which is almost double what the national is. We have access, of course, to lethal means. You know, firearms are part of our culture. And bottom line is, if all you have is a pile of pills, you're going to die about 3% of the time. Access to a firearm, 93%. Probably one of our biggest issues that's consistent in the Rocky Mountain region is stigma. We have that cowboy mentality, that sense of independence. We take care of our own. We don't like to talk about our problems.
Right,
especially when it comes to issues around depression or anxiety, we see it as a weakness, and we see ourselves as a burden. If you think you're a burden, how likely are you to ask for help? So we also have a lack of behavioral health resources. Then we have issues that are some unique ones, like altitude. That's consistent. If you take a look at the states at the highest, they run right down the Continental Divide. And that's, of course, that's a worldwide issue. It has to do with metabolic stress on our system from long-term oxygen deprivation. And then, of course, one that's also consistent in the Rocky Mountain region is we're rural, which affects our ability to get to help, but also crisis response.
Right. Yeah. Now, as a generalization, is there age groups that are maybe more prone, or that you see more this happening with?
It is usually the middle-aged men, but you know that's unfortunately something that we deviate a little bit from the national. Nationally, it's about 45 to 54. In Montana, our highest rates start at 25 to 54. And so it's those middle-aged folks that are at very high risk. And then, of course, the elderly are at very, very high risk, and that is consistent across the nation.
You know, one thing I was thinking about this topic the other day, and it seems like socialization, that anymore people aren't socializing, they're not interacting. I mean, you can pick up your groceries, you can have this delivered, you can do that. You don't get out and see people. And after the pandemic, we didn't see people then either. How important is socialization?
That's that rural piece that makes it such a factor. But then add in what you're talking about. After COVID, we've isolated more. We're doing virtual meetings. We don't go into the office, that type of stuff. Socialization is critical. Isolation is a major factor when it comes to suicide prevention.
Yeah, and I guess we start saying, okay, what do we need to change in the future? And you mentioned so many different factors. What might be a top factor or two that we need to look at right away?
Well, I think one that we all can do is stigma. We need to start to talk about it. It's one of those last taboo issues that we don't like to really bring up, and it stops us from getting help. We have to be able to talk about it. People have to know that if they're experiencing depression and anxiety and they're experiencing suicidal ideations, that it's okay to talk about it, and they're not going to get judged about it, that they need to ask, they need to talk about it.
And when you need to talk about it, I mean, do we say, you talk to your physician, but there's also mental health care professionals. I mean, would your physician be the first one to talk to, and that they could address it by medication?
I think you can. Well, I would say that you start off with your primary care provider to see if there's they can assess you whether you have depression or anxiety. But you can also start off with a behavioral health expert, whether it's a licensed clinical social worker, licensed professional counselor, psychologist. If you're having those, to start off with that. It's critical that there's a collaboration, though, between behavioral health and primary care, and that they work together. So I think we always want to start by talking about the issue. We don't want to jump to medication. It's not about medication all the time. The counseling and the medication has been found to be the most effective.
And we're drawing to close on our first segment, but we have a new number. It's just a 3-digit number. It's not the 911, but it's 988.
Right.
And the purpose of this 988 number is to start the ball rolling, which Carl and I were talking about, is that where do you start? You can start there. And they can direct you to local resources which can start to address the issue and the problem, and they can do it, I'll say, anonymously. They don't publicize it or anything, and you can take that first step. Or if you see these certain things we'll be talking about in the next segment in a loved one, you can call the number and you can start the ball rolling too. So got a lot more great information. Stay tuned.
With as many as 1 in 10 Americans at risk for Alzheimer's or some other form of dementia, chances are someone you know and love will receive that diagnosis. When that happens, you may well feel devastated, but know that you are not alone. Help is available. You don't have to face dementia by yourself. Call the free 24/7 Alzheimer's Association helpline, 800-272-3900, for guidance and support.
It's been 27 years. I never thought I'd still be smoking, but here I am, COPD and all. I'm about to have a granddaughter. There's so much to show her, but I'm scared I won't be able to keep up like I used to. I kind of gave up on myself on quitting. But it's different now. I want to be here for her and for my daughter.
Every generation produces heroes, men and women who step forward to defend our country in time of need, no matter the personal cost to themselves. And though we can never fully repay them, we can make sure they have access to low-cost, long-term care when they need it. That's what Montana's Veterans Homes are all about. If you've got a hero in need in your family, call us. We can help.
Sergeant Jones. Please respond. I was separated from my squad. Requesting backup. Anyone? Please respond. I'm all alone here.
Welcome back to Aging Horizons. I'm your host, Brian Lamore, and we'll continue our discussion about suicide in Montana. We're in the top 5 in the nation quite consistently, and we need to start addressing that because it affects you and your loved ones and your friends. And rejoining us is Carl Roston. You're the state suicide prevention coordinator. But let's kind of start at the top. What are some warning signs? I guess you have warning signs that you'll see in yourself, warning signs in other people. What are first things we want to look for?
Well, there's a number of them, and what's important to understand about the warning signs, any one of these by themselves doesn't mean that the person's suicidal. It's kind of having they come together, but we're also talking about a change in character. The person didn't used to be this way, and now they are. So one of them is we start off is that they start to communicate, they start to talk about an intent of dying. Very seldom is it going to be direct, and that has to do with the stigma. I mean, if you think the person is going to come out and say, "Hey, I'm feeling suicidal today," that's not going to happen. It's usually an indirect statement. I can't take the pain. It doesn't matter what happens to me. Everybody be better off without me. Those are the types of things that you're going to start to hear. They may do it indirectly. They may do it in writing or social media. We see a lot of it there. They start to have a sudden interest in firearms, or they start to stockpile medications. The next piece is we often take a look at a change in substance use. So either they never drank before and now they are, or they're starting to use more and more of a substance. The next one is a sense of purposelessness, where they start to give away prized possessions, or they start to give away things that are of value to them, and it could be it could be whatever's of value to that person. Also, deterioration in personal hygiene. We often see that. There's often a change. An agitation or anxiety, difficulty concentrating. Changes in sleep is one that we often look at. There's also a sense, almost a sense of that it'll never get over. There's a kind of a tunnel vision, a focus on it, where they think this is how it's going to be, this is never going to change. It's that cloudiness that they have, often associated with depression, and a sense of hopelessness. No goals, no future orientation, and they start to withdraw. They start to pull away from family, they pull away from friends. They stop doing the things that they usually find pleasurable, and that's a huge one. We often see that as they stop doing the things that they enjoy. There's often an increase in anger or agitation. They're on edge. That type of thing. They start to engage in reckless or high-risk behaviors, and it could be there could be many different things. It could be substance use, it could be gambling, illicit drug use, that type of stuff. But an overall one, the last piece, is a change in mood. They're just not acting like themselves. Something's gone wrong.
Mm-hmm. And is it correct that it's kind of a cry for help? I mean, if you are observing this in another individual, or is it more
well, it often is. I mean, the anger, the agitation, they'll say it. Many times there are subtle warning signs, but it is often, we have a tendency to want to discount it, and most of the time it is a cry for help.
Yeah, okay. Well, so we recognize these in an individual, and what are the first steps one can take to initiate a conversation? Because many times people don't want to ask about that. It's a tough thing to bring up.
It is, and there's a myth out there that if I bring it up, I could put the idea in the person's head.
Yeah.
There's not 1 ounce of research to support that. Not one. On the contrary, what's critical is that we have to be able to use the word suicide. We have to be able to ask somebody, are you suicidal, or are you thinking of killing yourself? You're not going to put the idea in the person's head.
Right.
If you saw the warning signs, they had it, they were thinking about it way before you ever brought it up.
Yeah.
What it does, though, is when you ask somebody if they're suicidal, it validates their pain. It acknowledges that they're hurting. It creates a sense of connectedness. It brings out the ability to talk and a sense of hope. You can do no harm by asking somebody if they're suicidal. I often tell people, though, you have to be careful. You don't want to ask somebody if they're thinking of hurting themselves. That's completely different.
Oh, okay.
Because, when people are in crisis, they often think very literal.
Yeah.
No, I'm not thinking of hurting myself. I'm thinking of killing myself.
Yeah.
So you have to be able to ask them directly, are you suicidal? You can do no harm by doing that.
Well, you do no harm, but my first thoughts are, if someone asked you that, no. And, because that's an automatic reply.
It is.
And how do you see beyond it?
What I often tell people, and the greatest fear that a suicidal person has is a fear of being judged.
Oh.
And so you may notice the warning signs. You may ask them if they're suicidal, and they'll say no. If you saw enough of the warning signs to ask it once, ask it again. It's the second time that they're going to have a better sense that you're not going to judge them. Now, the big thing is they may still deny it.
Yeah.
Well, what we want to do, that's where the 988 number comes in, is that we want to make sure that they have access and know about the 988 number, because maybe they haven't hit rock bottom yet. Maybe rock bottom's going to come that weekend, maybe the next month. But when they're in that dark, lonely place, when they think there's no other choice, guess whose face is going to pop in their head? Yours. And that's when they may make the number, or make the call.
Yeah, because they remember you asking, be concerned enough to ask. What I see when they advertise a 988 number, it's like an individual's considering suicide, call it, but a loved one, a concerned person could call it to gather resources. And how is that a different approach for the individual calling in?
Well, and that's a great point, Brian, because a 988 can be used by the person, but if you're also concerned about a loved one, you can. So we get a lot of calls from people who, I'm concerned about my cousin in Billings. So they can actually initiate contact, whether they're in the same city or not. Matter of fact, nationally, we get calls from other states, or the 988 will call us saying, hey, this mother in Tennessee saw that their daughter was doing this in Montana. So it could be used that way. We actually train people, though, to also use 988 because they actually can do an assessment over the phone and determine if the person needs to be taken to the emergency room or if any type of crisis response needs to be done. So 988 is not just for the person in crisis, it's for people that are concerned about others that might be.
Oh, that's great. We've drawn to a close on this segment. We'll be right back. You've probably seen some big-name celebrities on your TV lately talking about all the Medicare benefits you're missing out on. But the insurance companies who are paying for these ads may be pushing benefits not available in Montana. Fortunately, help is available from a friendly state health insurance assistance program counselor who can help you sort it all out. It's free, and we screen everyone for eligibility regardless of your zip code. It's Montanans helping Montanans. Call today.
Today, class, we'll be discussing the term ombudsman, a word we borrowed from the Swedes and never gave back. Say you're a resident or you have a loved one in long-term care. Now, what do you do if you're not happy with the care and services you receive? You call your long-term care ombudsman, of course. Your ombudsman is available to support you and your rights. An advocate on your behalf could be the ticket. This is your home. If you have questions, the numbers right there below me have all the answers. Class dismissed.
I was diagnosed with diabetes in 1992 and I went into denial. It made me angry. I was a professional chef and I didn't want to change my eating style. It took me a long time to get serious about managing my health. My perspective changed from resentment to one of loving my body, the container for my spirit. Getting help from my diabetes educator supported my goals of improved self-care. I want to feel good and have a great life. My diabetes educator helps me do this.
A decade of Montana fourth graders on Energy Share. Robbie Holman reminds us that even during the chilliest Montana winters, our homes don't have to be cold, not if we Energy Share the love. And Emma Bergman knows who to call when the cost of heating your home starts to put a chill on your family. Emma says, when winter is in the air, it's time to care with Energy Share. Energy Share is not a government program. It's neighbors helping neighbors who face energy emergencies the Montana way. Call or visit our website today. Thanks, Energy Share, for helping people in need.
Welcome back to Aging Horizons. I'm your host, Brian Lamore, and we're continuing our discussion about suicide in Montana. We're regularly in the top 5 in the nation, and we want to address that. And we have an individual that his job at the state of Montana is suicide prevention, Carl Roston. Now, when we left our last segment, we're talking about 988. Just 3 digits on the phone, just dial 988. What kind of resources do they have for a loved one who's concerned about someone and for an individual who might be considering suicide?
So first of all, 988, it's technically been around for a long time. It's been around for generations. I mean, about 30 or 40 years. But it used to be the 800-273-TALK. That was the National Suicide Prevention Lifeline. In July of 2022, nationally, they changed the number down to 3 digits, 988, to make it more accessible, easier to remember. And they really wanted to focus not only just on suicide, but crisis, anybody who's in crisis. And so how the system works is that we have 3 call centers in our state. We have Voices of Hope in Great Falls, the Help Center in Bozeman, and Western Montana Mental Health in Missoula. They separate the state equally, as far as it's usually based on population. And if you call 988, you go to your nearest call center, goes to the nearest call center. And the way the system is set up is that we really want to try to reduce the probability of getting a busy signal. So the way it's set up is, say if you call in the Bozeman area and all their phones are busy, it goes to the next available call center. But that's not just Montana. I mean, it goes to anywhere nationally. So, for instance, we get a ton of calls from California, Florida, New York, because we want to make sure that there's always a person talking. And the way the system works is that when you call up, you can, if you're a veteran, you can hit number 1 and it goes to the Veterans Crisis Line. 2 is for Spanish speaking, and now they've added a 3rd, which connects them to what's called the Trevor Project, and that's for our LGBTQ population. But if you don't press any of those, then you go to that local call center. And usually we've done really well. Montana actually has one of the highest in-state response rates. About 98% of the time the call stays in our state, which is important because people don't want to talk, Montana people don't want to talk to somebody in New York. But we've also cut down the response time from in the past year from about 32 seconds down to about 8 seconds. But here's the important one. It's not just a crisis line. In that what we have found is that about more than 70% of the calls, the issue is resolved on the phone. And that's important. Only about 8% of our calls require 911 intervention, mobile crisis response, emergency response. So it's important for people to know that this is a resource. Sometimes we just need someone to talk to. We need to connect. We need to hear a friendly voice on the other end just to get us through the moment. And so 988 is a critical part of that. They can do an assessment over the phone. And it's the same type of assessment that you would find if you went into your doctor's office or a mental health office, that they can screen, and they can, and if needed, they can determine if crisis response needs to happen. The calls are confidential. They don't go anywhere unless there's imminent risk. I mean, if they figure out, if they determine that it's high risk, then they can send resources. Right. But other than that, it's not. It's anonymous. It's confidential. We often, one of the things that they do nationally, which is critical, is that they do a callback with the person. Because if someone maybe just needs to talk, someone's going to call them back the next day just to see how they're doing.
Yeah.
And that's a critical piece. That's called caring contact. And that's a critical component. And if you think about that, that's something we all could do.
Yeah.
I mean, we don't have to be on the call line, but you know, you're worried about a neighbor, seems really down. Do a check-in with them. Call a family member or a friend who just seems a little down. Say, hey, how you doing? Just wanted to check in on you.
Be a friend.
That caring contact is actually, there's a ton of research to show that actually reduces the risk of suicide.
Oh, that's interesting.
Yeah.
Well, now, we were talking about the 988 number, but there's other resources out there and trainings for health professionals, including law enforcement. Tell us more about what Montana's doing in that arena.
Yeah, we have a lot of different trainings. We do a lot of trainings with law enforcement, first responders. There's one a great training called CIT, Crisis Intervention Training, that trains officers how to respond when they're dealing with a mental health issue or type of crisis. We also do a lot, one of our biggest pushes right now is with primary care, because almost 45% of all people who die by suicide in the United States saw their doctor within a month of their death.
Really? Wow.
And so we do a lot of stuff, it's basically what's called the Zero Suicide Initiative, but it's suicide safe care, where we train nurses and doctors how to do a risk assessment, how to do a safety plan, how to do an assessment for depression and anxiety, because it's a critical piece of primary care.
Yeah.
And so we offer those. We do a lot of programs in schools. We know that the biggest piece that is often lacking, one of the cliches we always say is that suicide occurs when the pain exceeds the ability to cope. So teaching people coping skills, resiliency. Yeah. So we have programs, and we have some of our programs start in 1st and 2nd grade. We have programs for schools, and those programs have been found to be effective 30 years later. So a lot of resiliency training in schools. Screening in schools is critical. Early identification. The average age of depression is usually about age 15. Anxiety is age 11. Yet for most people, they don't get treatment until about age 30. So if we start doing the training where we start identifying in adolescence, early identification has the best prognosis.
Okay. And then you're a resource to the state of Montana. These groups, they can contact you, and you can hook them up to trainings and information. Right?
Yeah, we have trainings or local resources. We also have a lot of what we call postvention. And that is, there's often a contagious effect to suicide, especially in a small community. And so we have postvention toolkits that communities or schools can use on how to manage after a suicide to reduce the risk of suicide in other people. So all those resources are available through the state office.
Well, that's amazing. Well, Carl, thank you so much for being on the show. So much information. I think we could talk for an hour.
Yeah, we probably could.
And for our viewers, again, Montana is one of the top 5 in the nation consistently for suicide. As Carl has noted, we have programs out there to help address, education, so you can recognize it in other individuals. But if you see something in someone you know or love, ask them. Just come out and ask them. And that could be so much help in preventing a suicide. For Aging Horizons, I'm Brian Lamore. Thank you for joining us.
Special thanks to the Department of Public Health and Human Services for their continued support. Hosts on Aging Horizons are program specialists at the Montana Office on Aging. Production facilities provided by Video Express Productions. For more information about Aging Horizons, call the Department of Public Health and Human Services toll-free at 800-332-2272.